I'm Annemarie Thompson, and I'm a professor of anesthesiology, medicine, and population health sciences at Duke University, where I practice cardiothoracic anesthesiology and critical care medicine.
My name is Kirsten Fleischman, and I'm a non-invasive cardiologist and an outcomes researcher. I'm also a professor at the University of California, San Francisco, where I serve as an assistant chair in medicine and associate chief in cardiology, and as a medical director, specifically of our adult cardiac stress and ECG laboratories at UCSF Health.
My name is Nathaniel Smilowitz. I'm an interventional cardiologist and clinical investigator and assistant professor at the NYU School of Medicine in New York, as well as the VA New York Harbor Healthcare System Manhattan campus.
Can you talk about what is still left to be learned with the management of patients with myocardial injury after non-cardiac surgery? Like, what should the clinician do once that's identified?
Yeah, this is a really challenging area, and it continues to be an area in need of investigation. We have observational data to suggest that statins, aspirin, and antithrombotic therapy are probably beneficial for these patients. We have a randomized trial of anticoagulation, which reduced a composite of cardiovascular events in the year or two after non-cardiac surgery in patients who develop myocardial injury. But we still don't have a complete consensus or a clear framework for the optimal care of these patients.
Kirsten, you're a cardiologist also. What do you do when you get a patient who is identified as having MINS?
We have somewhat limited data on actually how to treat MINS, but we know that it portends increased risk down the line. So I'm going to do a very careful evaluation of that patient. I'm going to treat every risk factor that I can manage effectively, and certainly I'm going to surveil that patient as far as future ischemic risk is concerned. Nat, do you do any additional testing in those situations or more risk factor management?
I think it's really about risk factor management in these patients. Certainly it might make one give pause to what might otherwise be symptoms that are ignored in the course of clinical care subsequently. But my goal is really to make sure that they have optimal lipid control, optimal risk factor management, and I do weigh heavily the consideration for at least an antithrombotic agent long term, whether that be aspirin or a different agent.